Wow, guys, I did not realize, only when I hear the energy come from you guys, how complicated this topic is, how important it is, and the fact that nobody seems to really be focused on it.
It doesn't have a quick ROI. Everything that we do, everyone wants to know where you're going to see a return on investment in 90 days, in 6 months, maybe in a year. We're talking about things that are going to be important, years into the future, and people don't invest that way.
I think at the high executive level, there is a general narrative like, we don't really have to do data governance because AI is going to solve for that.
Correct.
They think it's a magic wand.
So let's talk about ChatGPT or Gemini Pro. So Zach Cohen, the editor of the NEJM AI, was at a conference with him that was put on by him and his fellows. And it's crazy how when you look at all of the commercially available GPTs that are out there, and they're being used on rounds every single day.
Oh yeah.
Their propensity to treat what we would all consider a case that needs hospice care is shocking. So John and Howard brought up the garbage in. What I'm saying is, even if it was clean in, you have to be open to the idea you're getting garbage out because of what it's trained on, medically speaking. And his fellows and his lab, they have papers on these kinds of biases and intentions to continue medical treatment in someone we would all consider an end-stage case. And it's shocking. And the more we lean on this and don't realize it, are we solving a problem or are we perpetuating one?
Well, Mark, it's a great point because they want to please, and probably one thing they don't want to do is kill people. One of the treatments isn't do nothing.
Yeah, one of the greatest ICU sayings is don't just do something, stand there. And there are times when that is clinically appropriate care in an ethical, humane way. And I don't think the GPTs are comfortable recommending that at all, even with patients' wishes stated, et cetera, et cetera.
Welcome to Beyond the Blueprint. My name is Greg Malkery. I'm the managing director at Lighthouse Health Tech Advisors. Data governance is not a policy binder or committee structure. It's how a hospital decides what data means and who can act on it. This episode is part of our collaboration with AMDIS, the Association of Medical Directors of Information Systems. To help me unpack this, I've invited 3 nationally renowned informatics leaders who see these decisions up close every day. We have Dr. John Lee, president of HIT Peak Advisors and former CMIO at Allegheny Health. He works with health systems to rebuild trust in their data. We have Dr. Howard Landa, CMIO at Adventist Health. He focuses on how data quality and data decisions affect daily care. And we have Dr. Mark Pierce, former CMIO at Parkview Health System. He's seen firsthand how weak data governance shows up during care delivery. So today we're going to step out of the theory and get into real hospital work. With that, why don't we go beyond the blueprint? Today we're going to be talking about data governance and why it matters for patient care. When governance is unclear, here's what happens during a real shift. Nurses hesitate because they're not sure which data to trust. This forces them to stop their activities, double-check information, or wait for confirmation. Nursing hesitation slows down care, workflows back up, patient handoffs slip, and patients feel the delay. And this is why data governance is not an IT issue, it's a patient safety issue. Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. So with that, let's start by looking at what hospitals are dealing with right now. Now, most hospitals say they have a data governance strategy, but many cannot explain how it helps during care. Mark, can you share a moment during a real shift when clear data rules helped bedside staff act faster? Or alternatively, when unclear rules changed what the staff did during a shift that slowed care down or created hesitation?
Yeah, absolutely. I think when you look across organizations, you can see examples of both readily. In terms of rules helping you act quickly, you can imagine a scene in an ICU when a sepsis risk score or a deterioration index score goes up, and trust that the data's right, the data's validated, would lead somebody to act quickly and stay ahead of the game. The flip side, and you see these all the time as well, is when it's not clear, especially in things like MedRec. What do you do when a pharmacy feed has 2 medications of the same class and the human entered MedRec has none of those or one of a third. The pause, the backtracking, the delay to figure out what's what you can prescribe, what they're used to, what they're on, what they handle. Those sorts of delays are things that you see every day, every admission, not uncommon in a healthcare scenario.
Beautiful, Mark. All right, John, when you look across hospitals that you work, how do you know data decisions are shaping daily care and not just written down or talked about in meetings?
The truth is, to a large extent, you don't, which is actually part of the problem that we're trying to address. The reality is that there's a lot of seat of the pants decision making, both transactionally at the front lines of care and also strategically and at a tactical level operationally. And to your point of what you just talked about with medication reconciliation, it was not that far in the past that the default medication reconciliation path, the way that it was actually executed, was that a physician would write this order within the admission orders. Continue all ambulatory medications, period. End of phrase. That's it. That was medication reconciliation. And then it was just dumped on somebody else. The problem is that we have so much information coming in that it's hard to parse all that stuff out and figure out what are the things that are most important to me to actually deliver to my patients in care. And that's what I think we need. That's the major problem that we need to solve.
Great point, John. Howard, when data rules are unclear, what do clinicians notice first during a normal shift?
Yeah, there are so many different areas that this can impact. Clinicians rely on the data they have being accurate and being available. So one example, we're going through an EHR conversion. We're taking a ton of data from multiple systems and pushing it into a new system, not to be the system of truth, the source of truth, but to make all that data available to our clinicians to help facilitate care as they transition. If that data isn't mapped correctly, if that data doesn't come across and the data point from system A doesn't come to system B in a place where it makes sense and it is consistent, that can impact care, can slow things down, and can really impact patient quality, the quality of the care we deliver, and patient safety. Taking that one step farther, even after we're live, looking at governing what data comes in and what data we share to other organizations, because we can pull data in from other places. If that doesn't come in correctly and consistently, that can mislead people. And we can be sending data out that, if it isn't well governed, if it isn't well identified, that can negatively impact care somewhere else. So all those things are critical to as we do our transition and ongoing.
How badly to organizations, or are organizations aware of how good or bad their data is? How well organized it is? Is it duplicated? Is it accurate? What's the sense you have of most organizations that you guys have encountered?
I think there's an underlying. Okay, John.
I think just juristically, at the operational level, at the leadership level, they understand that data is kind of bad, but I don't think they truly understand the enormity of it, nor the granularity and the specificity of it. Howard mentioned this data transition that he's experiencing going from Oracle to Epic. To borrow a legal term, you have errors of omission and errors of commission. I would actually add that. So I think in most of the circumstances where we have friction points using health IT and information delivery, it's mostly errors of omission. But I would say that the one thing that I would add is that there is another type of error that we often experience with, and probably is actually the most common, and that's errors of opacity. So that the data is there, but no one actually sees it. The metaphor that I often use in this situation is that the last scene in Raiders of the Lost Ark, where you have the Ark being crated up and putting into some sort of warehouse. That's kind of what we deal with on a daily basis as we deliver care. The answer is there somewhere, but nobody can find it.
So I would piggyback on that and say, actually, Greg, to your point, this whole thing is siloed, right? Take a simple concept like length of stay. Even though we, in this day and age of enterprise data warehouse, if you ask finance what length of stay is, it's an integer number at midnight when someone's in a bed. If you ask a clinician, it's different. And the discipline on a very simple metric like that's an everyday conversation in healthcare, multiply that by every other metric. It's just siloed in terms of really understanding the breadth of the data that we have, the need for good governance. And by that, we mean terms, clear definitions, blue ribbon certified, accurate data to the best of our ability, and the application of that. And I think that's part of the biggest challenges that data governance and good data governance can help us overcome is the organizational understanding that there in each organization are so many different definitions of a very simple metric that we oftentimes get ourselves into trouble with trust and other things that we'll talk about later in the podcast.
How well do other organizational leaders understand the problem of data governance, and is it considered a high investment priority?
The problem you run into is at the front lines, they just assume that all the data they're getting is pristine. As you get higher up in the organization, you realize how messy it all is. But at the point of care, they assume everything is fine. I think leadership understands it. It's kind of an ethereal concept, though, trying to make all of this correct. And whose definition of correct? To Mark's point, a length of stay or a hospital day is different to a finance person, to a hospitalist, to someone investing in your organization. So how do you make all of that consistent? And not just within your organization, but to be able to share that data and when you compare organizations. So I think all those things make this gray. And when you look at all the other priorities that hospitals are dealing with and the financial implications of HR1 and others, it tends to be something you guys go figure it out. And it doesn't rise to I don't think C-suites are discussing this. I think the people below them are very worried about what they're not seeing.
So I think that the higher you go in the organization, they recognize that data and data quality is an issue, and they are all very gung-ho to trying to solve it because they understand what a critical issue it is until you actually describe the process on how to actually clean it up. And then they kind of wrinkle their forehead and they realize, that sounds really, really hard, and that's going to take a lot of time, effort, and money. You know what? We need something that's going to give us a positive ROI in the next 90 days. Let's kick this can down the road.
Well, you bring a really good point up. In the best scenario, let's say you're at 26 hospitals, how easy is it to actually clean up the data?
Not at all. I mean, everyone has their own, what they need. Again, going back to Mark's length of stay, everyone's reporting it in a different way to what who they report to needs it. And then when you look at the front lines and you're saying, okay, we need to reduce length of stay, and people start focusing on, okay, well, let's get patients out of the hospital sooner. Well, if midnight is your length of stay, that actually doesn't impact it. It certainly has a positive benefit to getting patients home sooner, but you do all this work and your numbers don't change because you're not looking at the same data point.
You bring up a really interesting point. So one is we have to determine what the length or what the enormity of the problem is, right? So we have to do an assessment from there. And then there's the commitment to actually putting the resources in place to actually solving the issue. It sounds like this is a pretty substantial investment.
It is a big investment. And what I'll tell you is it's an investment that sort of seems to dwindle over time. It is a big investment of time. And it is a long, tedious, and laborious process. Organizationally, you see good folks fall by the wayside quickly. So once your meeting attendance was all 30, all 10, all 8, and then it's 7, then it's 6, and then there were 3. Right. And those 3 are the people who feel like they're holding the charge now, and they're usually IT focused that stick with it. And I'm not sure that's the best way to go forward, Greg. At least that's what I've seen at other organizations. Howard, John, does that resonate?
I would actually, when you say that it dwindles over time, I think the appetite and the enthusiasm may dwindle, but I have yet to see an organization get to a point where they get to a critical mass of really, really good quality data and having a library of these data assets that are so clean and so well curated that they basically can be used and assembled like Lego blocks. Because then what ends up happening is that then the value of these data assets starts hockey sticking up, because you can then start asking questions and get the answer right away and then act on it right away. And then once you act on it, get more iterative data back to then be able to iterate and improve things on a very nimble basis, very almost agile-like. And nobody really does that yet.
Well, let me give this go on.
So the one thing that I often cite is that in healthcare and healthcare IT, we don't really have a PDSA cycle most of the time. We have a PD cycle where we just heuristically think something's a good idea. We put something into action. We don't really measure its output, and then we go into the next project and pat ourselves on the back that we accomplished something.
Let me get this straight, John. So right now, the buzzword is AI, and everybody wants to kind of get on board. But what happens if the underlying data is not accurate?
I think a representation of that actually was a few years ago when the Epic sepsis model got a black eye on within the context of a few very high-profile organizations. I think University of Michigan might have been one. But the reason why it did was because the model was trained on data and data types and data sets that were probably very dissimilar to the places where it failed at. And I know that in my organization, when we implemented this sepsis model, we had an AUC of about 80.85, which was actually quite good. But that's because the way that we modeled and curated our data was very similar to how it was trained in the first place. So that sort of normalization and the quality of data is really super important to creating outcomes using these AI tools that actually are positive. And until we get to that point, I think a lot of the leadership see the shiny object and the very slick demos. So they see the end product and they're all focused on that and like the algorithms, but they don't understand the grinding hard work that you have to do to clean up your data to make those things work. And the irony of this is that if you actually did clean up the data and spent the year or two to actually institute a good data governance process, I think that you would 10x your organization at least, because you would be creating content and data assets that would allow you to iterate and execute way more efficiently.
Wow. Howard, as you represent a large hospital system, what breaks first when teams don't share the same data definitions across your hundreds of ambulatory environments and hospitals? Is that a problem?
I think, as Mark pointed out, when you start looking at things from a enterprise perspective around length of stay, days in the hospital, the length of a hospital day, those metrics become very difficult to share and to understand and to act on. To John's point about having data that isn't solid, you start taking actions and we go down the wrong paths. You asked about AI and data. I think, my CISO likes to tell me that if you have 5% bad data that a system was trained on, every single answer will have an error in it. So when we get to that point, if our data isn't clean, that's going to affect everything from the quality of the care we deliver, the way clinicians interact with our systems. So all those things get in the way. Really specifically at the point of care, again, they trust that this data is right. So if it isn't, if a sepsis, we talk about sepsis predictor or a deterioration index, or even which patients need follow-up, isn't accurate, we start spinning our wheels, wasting time and resources, and negatively impacting the care we deliver.
I would think hospital risk management would be very much concerned about this, right? A doctor made a decision based on a set of faulty data, but he followed evidence-based medicine, but the data was wrong.
I mean, I think, as John pointed out, data can be hidden. So if we don't have that data structured and available, and this is where I think AI might be able to help us, because it can read, human created text and extract data and give us, better data on that side. But if it's not, if we don't have it all, it's really easy that error of omission that John mentioned becomes really prominent, and you start going down a path because you don't know you didn't know something.
Hey, John, you're an ED doc, right? So during a normal shift, what happens when you have data disagreements and you've just gotten that 70-car pileup on the highway? Who settles these disagreements, or are they settled?
You guess. I think oftentimes on the front lines in clinical situations, you have to, you're often in a position where you have to guess. You have to just kind of presume. So here's a perfect example that was actually a real situation for me. There was a patient who came in and he clearly had a stroke. And I forgot what were some of his other clinical situations. We were concerned that he was on anticoagulants because of some of the other clinical features surrounding his presentation. But he had zero information in the system. And he was completely fresh to us. And we had an opportunity of like maybe 20, 30 minutes to decide, hey, do we give thrombolytics to this patient? And we just had to guess. And fortunately, he did okay because in retrospect, what happened was that we did find out that he was on anticoagulants, but had been non-compliant and had stopped taking them years ago, which I think probably ended up causing a stroke. But at that point in time, we were just it was a very sphincter tightening situation, because we could either let him continue with a stroke and be permanently disabled for the rest of his life, or we give him the thrombolytics and maybe cause him to bleed inside of his head. And we were on the knife's edge with that. That's the sort of thing that we deal with on an ongoing basis.
So I'd bring up this point, Greg, and that is that this story ended positively, right? It was a guess. So we were relying on the data. The data wasn't there. There was some inconsistency with the clinical presentation and the data. What do you do? And as John mentioned, incredibly sphincter tightening at the point of care. This one turned out well, but let me tell you about the doctor where they make a mistake based on that wrong data. Those are one of those things that stays with that clinician forever. And once that trust in the data is gone, it's not next case I trust it again. It's not next month I trust it again. It's a conversation in the physician's lounge. It's, well, gosh, I don't know about this system. Once that trust is broken and there's something that comes out suboptimally, that's something that organizations and physicians and departments have a hard time bouncing back from. And it's really, again, highlighting why this data governance is so important. You can't just fix trust once you've been at the point of clinical decision-making and been let down by the data.
Wow.
It also underlines another issue. We may spend huge amount of time and energy and money doing data governance internally, but everything that was just described is all about someone else's data governance, whether it's an outside system that's bringing it in, or an outside provider entity that has that data, or a lab or a radiology group. All that data has to come in, and we just blindly rely on it. You get data coming in with, here's a patient who has 16 different things on their problem list. Everyone disagreed on exactly what that was, because there was no governance and how to assign those problems, because a person did it. And now you're trying to figure out how to take care of someone who, in John's case, can't give you information, and you're relying on those outside data sources to make your decision. And there's not like you can go say, that provider organization has got good data governance and I can trust it. And this vendor system has bad data governance and I don't know what's coming through from there. They just assume it's all correct.
Where are you getting the greatest pressure from? Which constituents within the organization are most concerned? If I'm a heart surgeon or I'm an OBGYN, I'm being sued all the time, right? So are clinicians pushing on you guys? I need more accurate data. My license is on the line. My livelihood's on the line. Where are you getting the pressure from? Who's stepping up and at your office of the CMIO?
I would jump in and say, I don't think there's necessarily a specialty that does it. And I don't hear a lot of that in my formal role. And that's what's most concerning, Greg. The silence is what's really concerning, because we know there are issues that are out there every day. And what happens when those issues aren't surfaced is there's a quiet workaround that starts to happen, or a quiet distrust that happens. So maybe John and Howard have a little bit different experience than I do, and there are people banging down on their doors. I would tell you, if that happened, I think that would be the sign of an incredibly healthy organization, and one where you could really start to beat the drum and move forward with data governance. But honestly, it's the silent, gosh, that really burned me. What do I do now? I'm going to do something different later, that I think is the bigger issue. John, Howard, anything different?
I think to your point, frontline clinicians very rarely bring things like that up. Now, again, if all of a sudden someone had bad data that came from somewhere and a bad decision was made, we'll hear about that either directly from the clinician or through the quality review process. But that doesn't, it's usually again, back to the sin of omission. You didn't know what you didn't know. You took an action. It didn't go perfectly. It was okay. It could have been better. And then you move on to the next thing. Most of the asks around data governance are coming from not beating on the door, but beating on the ceiling from people higher up who understand what they're seeing, maybe the quality department, finance, others who are looking at it and saying, I don't know what to do when I have 3 dashboards and they all have the same alleged data point and they all say something different. That's when you hear about it.
As I'm hearing you here, it seems that the quality department would be up in arms about this. It would be one of their top line initiatives to focus on.
If they didn't have 100 other top line initiatives, probably.
Exactly.
Well, but the thing is, I think that most of the time, my experience is that the quality department doesn't really know how to solve the issue from a data perspective. And they don't necessarily even understand the mechanics of what we need to do to actually clean up our data. To, I smiled a little bit when Howard said the outcome was but at a macro level, that's our entire healthcare system. It's, sometimes we do good, sometimes we don't do so well.
Lots of opportunities to do better.
Yeah, and
Mhm.
that is a structural issue that we deal with in healthcare.
Let's have some practical advice for our audience members. If a leader wants to help teams move faster without changing systems, what's one clear data decision they should make this month?
For me, it's not so much of a data decision, but if you're talking about how do we get data governance to actually move forward,
Yeah.
I think you need to look for low-hanging fruit. I think you need to look for things that people actually can see and touch and feel because, to the points that have been made, we can spend a lot of time, energy, and money creating something that still is fairly opaque in the background, but something, and then where I push is something like data sharing. With the 21st Century Cures Act and the requirements for data sharing and anti-information blocking, figuring out what we share, how we share it, who we share it with, I think is something that has real frontline impact and might be the best way to really kickstart those efforts.
Yeah, I would
Both you,
agree.
John, and Mark's good.
So
I think from the bucket of do common things uncommonly well, start with something that already has horses hitched to the wagon. So if you're on a big length of stay improvement, get some governance around that data definition. Make sure that the data that supports it is Blue Ribbon certified and clean up what has everyone else's attention. I would put forth that data governance in and of itself is a tough row to hoe in an organization. Hitched to an ongoing initiative and folding that into it might be a better way to get momentum and activity going forward.
John,
Go ahead,
what do you
John.
think?
I think one of the biggest opportunities is taking granular bits of data and putting them together and synthesizing some sort of insight from it. So length of stay or readmission, for instance. I was actually, right before we got on this call, I was working on an initiative to conceptualize a patient who is currently hospitalized or within a patient's record that is where the patient is hospitalized. The patient have a future hospitalization. Now, that data actually exists, but it's in disparate pieces. But if you assemble it into, from a database term, a single column that people can easily access and understand, that makes a huge difference because then people don't have to keep chasing the little bits of data and assembling them all together. That is a huge opportunity because I don't think most organizations have actually gone and done that hard work and done it in such a way to make it easily accessible to the clinicians and operators who make a lot of these decisions on the front line. And for the Epic people out there, the mechanism that I'm using to leverage this is some of the registry infrastructure, which I think is highly underutilized.
Can you, any of you guys give me an example of an organization who's leading on data governance? Anyone who's done it right, that's been identified, in the trade press or in your circles?
I think one of the problems is if they do it really well, you don't see anything. And and it's not something people don't stand up and brag about that. They brag about the results from doing data governance well. So I'm not sure, at least in my experience, I couldn't say this organization is doing it well and this is doing it poorly.
I would call out one of our friends that we all know really well is Amy Siddipati at UCSD.
I was going to say,
Okay.
They've done some fantastic things with some of the things that I just talked about in some of their population health tools and really leveraging that sort of abstraction and creating higher level understanding and insights using some of the native Epic tools so that they can actually get better outcomes.
Mark, what are your thoughts on this topic?
Yeah, I'm leaning more towards Howard's piece on this. Really haven't seen an organization that I would say, wow, that's a model that needs to be reproduced locally. I think a lot of times the folks that are doing it right are the ones that you don't hear much about, but they are the ones that when you kind of look at their results and some of the things that they're able to do in terms of predictive models, in terms of clinical safety, in terms of actually building the foundations for AI and some of the build your owns, my guess is that if you were to look for some of those leading edge folks underneath the covers, you'd find good data governance for that success as well.
Excellent. So it sounds to me like if you're doing it right, let's say at UCSD, this is a part of the DNA of the organization. It's a fundamental building block on changing things, but they're focused on what the outcomes were because it's already part of the DNA.
And I think part of the big reason for that is that they were able to put multiple pieces and levels of organization and operations together and assemble these insights and connect it with some of their population health financials and incentives that they have currently within their system. And just to give you an example of the time and effort and resources that sort of thing involves, at one of my previous organizations, we had, I think, 2.5 FTEs dedicated to the type of things that Amy and her team did. Amy's team consisted of about at least 24 people in a smaller organization. And so that's the sort of effort I think that needs to be supported at an executive and organizational level. People who make these sorts of decisions need to understand that if you want to make these sorts of changes, you need to dedicate resources.
Great points, guys. All right, I'm going to switch things up a bit. Mark, I'm going to turn it over to you. I want you to turn to John and Howard, and I want you to ask them a direct question about data governance and ways in which leaders may not be looking at it today. So I'd love for you to talk in CMIO terms to each other and frame a question that puts them on the spot.
Yeah, let's do it.
You can make them uncomfortable. It's okay.
No, fair enough. So, all right, guys. We all know the center of the buzzword bingo card is AI. It's AI this, it's AI that, right? And there are a lot of organizations that really haven't done the due diligence around data and analytics to get to AI, but they want to start with AI. What would be one foreboding warning and solution that you would give to a leader, a fellow CMIO who said, wow, my C-suite wants to start with AI. We haven't even got a data governance committee yet. What are the things that you would counsel one of our colleagues to help their organization understand where they need to start to get to where they want to go?
That's a good one. I think just taking a step back.
Mark.
Well, I think taking a step back and just saying, what is your data governance and your AI governance, and how is it aligned? Because the AI governance, we look at bias, we look at results. Spend a lot of time spending how much money is it going to cost us? But if that's tightly aligned, either reporting up through or aligned with data governance, then you can ask that question, okay, is this result that you want to get because you want to use this tool, do we have the data to feed it? And if we don't, you're just, again, a small amount of erroneous data, and you're going to be running off in the wrong direction and spending a lot of money, not just on the AI, but also on all of the things that you want to change based on the information you're getting.
So what I would say is don't focus on the hype-filled shiny objects. Don't try to create chatbots for your patients. Don't try to create some sort of weird automation. Use the AI to actually clean up your data. And I think if you end up with a whole host of really clean data assets, to a large extent, I think a lot of the fancy, shiny AI tools that are being promulgated become irrelevant, because if you have really good data assets and good abstractions, oftentimes what will happen is that the obvious answer will just surface up relatively easily because with even simple descriptive analytic tools. So use the AI to clean up your underlying data and do the data governance using AI rather than using the AI to actually deliver and operationalize.
You know how to take the fun out of a project, don't you, John?
I'm sorry, what?
I said, you know how to take the fun out of the project.
Yeah, it's boring stuff, but it's
necessary.
Yeah.
You brought up a good point, John. Are there in fact AI tools either being developed by Epic or third parties that are actually focused on data governance?
I have heard of one.
Only
but
one.
Okay. I haven't seen it firsthand.
Yeah.
I have a colleague at University of Iowa who speaks glowingly about Evidently.
Yeah.
I've actually seen some of their things that they've done way early on, and I can understand where that where that's coming from, but I haven't seen it firsthand.
Yeah. I think at our recent AMDIS meeting, Anthony Chang talked about the idea of using AI to actually clean up data. I mean, I can't remember the specific number, but he claimed a very large amount of data in our EHRs is inaccurate. And since they're created by people, I won't be terribly surprised. And looking for inconsistencies in that data, looking for contradictions, and surfacing that to a clinician to say, hey, clean this up. To me, that's data governance at the micro level. But yeah, I think it is something that could be super helpful. Again, I think if you go and talk to senior leaders about their shiny object project, this is not the thing that they're going to react positively to. Let's use AI to clean up this data. I think it would be a good thing to do.
Howard, interestingly, even if we do clean up the data, I have a curiosity around the data itself, right? So if you think of a lot of the data that each organization is going to use to build their own AI, think about what that is based on. It's based on a certain payer mix, a certain percentage of fee for service, right? So is that what you want your AI built on as you go forward into a value-based world and a different payer mix, right? So was MA around as far back as you're going into your data sets? And I think from an industry standpoint, I have a great curiosity to see some of the more closed systems, maybe KP or others, how their data sets compare to those of us that maybe have a bit bigger variety, less capitation, less of a culture of uniformity in practice. I still think there's a lot of data governance work to do before we can safely unleash AI into clinical medicine on a broad scale, and understanding these data sets are training the AI. So it's not just are they accurate, but as you and John both mentioned, what are the biases that are in them? What are the ethics that are baked into each of these data sets that we aren't even questioning at the moment? Because that's what our AI is going to guide us to be. And if we're looking for AI to be a game changer based on this data, this is where you have to start.
I think one of the big issues, you mentioned bias again, so much of all of our historic data, if you look at everything published, it's all biased. I mean, someone walked in and didn't eliminate all the biases in it. And then you take multiple studies around the same thing with different biases, and they could amplify or they could cancel out. And it's really a random event as to how that is going to happen.
Hey guys, I think we're out of time. This has been incredibly informative. You guys are absolutely awesome on a very, very complicated topic. So I guess for our audience, if you remember one thing from this conversation, remember this: when data rules are unclear, systems keep moving, the risk shifts to the bedside and leaders own the risk. I'd like to thank you for joining us on Beyond the Blueprint. I'm Greg Malcurry. I look forward to seeing you next time. Thank you.
Thanks, Greg.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.